To this respiratory review video. This will be a video on COVID-19 guidelines-based ventilatory strategies. My goal for this video is to save you all some time by reviewing some recent guidelines that have been put out on the ventilatory management of patients with COVID-19. There are a lot of resources on the internet at the moment with the recent global pandemic. A lot of them are opinion and anecdotal based. My goal is to avoid that as much as possible and have this be a review of these two guidelines that were published last week. The first is the Surviving Sepsis Campaign guidelines on the management of critically ill patients with coronavirus. And the second is an interim guidance from the WHO on the clinical management of severe respiratory infection in patients with COVID-19. So both of these guidelines, as guidelines often do, make recommendations based on different levels of evidence and different strengths. The Surviving Sepsis have recommend, suggest, and recommend against, and I'll be using these colors and terms throughout the talk. The WHO have a do this intervention, consider this intervention, and don't do this intervention, and I'll be using these colors to represent those in the talk. So we know that COVID-19 is spreading rapidly across the world. The information that's coming out on it is very dynamic. Hopefully this saves you some time in reviewing these 100+ page guidelines that they've put out. So around 19% of these patients are going to present with hypoxemic respiratory failure. Around 14 are going to need oxygen therapy, and about 5 are going to need ventilation in the ICU. In the critically ill COVID population, there are very large rates of ARDS. 60 to 70% of patients are developing ARDS, and the majority are requiring mechanical ventilation. You can see here that 63.5 need high flow nasal cannula, and around 40 are getting non-invasive ventilation. At this point, we've been beaten to death with the risk factors. I'll review them very quickly. Older people seem to be getting more affected by this. Male gender and patients who have significant comorbidities seem to be getting hit harder by COVID than other patients. As of the date of the publication of the Surviving Sepsis guidelines at the top, this was the case fatality rate, around 2.3% overall, with much higher rates being seen in those over 80, obviously much higher rates in the ICU population, and very high rates in the ventilated population. I'm going to talk about oxygen therapy, non-invasive ventilation, and invasive ventilation strategies, with the focus being on invasive mechanical ventilation and ARDS management strategies. So let's get started with that. So we'll start with oxygen therapy. Most of these patients, actually most hospitalized patients, are just going to need oxygen therapy. The majority won't need invasive mechanical ventilation. They suggest starting oxygen when the SATs are less than 92, which seems reasonable, and they recommend starting oxygen when the patient's SATs are less than 90. So nothing too novel so far. In terms of SpO2 targets, they acknowledge both the benefits and the potential deleterious effects of supplemental oxygen and suggest that SATs not be kept any higher than 96% and to target a range of 92 to 96%. The WHO take a slightly different stance. They say that once the patients have had their kind of initial resuscitation with oxygen, that you can keep their SATs greater than 90, unless they're pregnant, and then they would like the SATs 92 to 95. And those are both strong recommendations from those two groups. You'll start off with conventional oxygen therapies. This will be low flow nasal prongs, face masks, that kind of thing. And both groups kind of are in agreement on that. Then they suggest if patients are not able to be kept normoxemic based on these ranges with conventional oxygen therapy, the Surviving Sepsis guidelines suggest moving to high flow nasal cannula. They suggest that if you can't keep the oxygen levels up on conventional oxygen therapy, they also suggest high flow nasal cannula over non-invasive ventilation. And they cite a few trials, one showing the decreased risk of intubation with high flow nasal cannula versus non-invasive, and then a couple showing the increased risk of transmission of disease to healthcare professionals with non-invasive ventilation as opposed to high flow nasal cannula. They also cite increased comfort with high flow nasal cannula. And the WHO are in agreement with that and have this as a consider in those three categories. In terms of the risk to healthcare professionals with high flow nasal cannula, this has come up a lot. In these guidelines, suggest that the high flow nasal cannula do not seem to increase the risk of disease transmission to healthcare providers. They place high flow nasal cannula in the same category as conventional oxygenation in terms of an environmental contamination risk, and they cite some sort of precedent data from the SARS outbreak, which suggests that healthcare professionals that were exposed to high flow nasal cannula were not at an increased risk of contracting SARS during that time. So it seems reasonable to use high flow nasal cannula in patients with COVID-19, at least based on these guidelines. The next thing we'll talk about is non-invasive ventilation. So non-invasive positive pressure ventilation. Here are a few of the interfaces that you might see patients on. The most common would probably be the face mask, but we're seeing more and more of these helmets getting used. So you may see either. They make a few statements on non-invasive ventilation. They essentially say if high flow nasal cannulas are not available, they suggest a trial of non-invasive ventilation with very close monitoring for deterioration and early intubation in a controlled setting if the patients are deteriorating. And they suggest some caution around patients deteriorating on high flow nasal cannulas and non-invasive ventilation. They do not make any recommendation about the type of interface for giving a patient non-invasive ventilation. They were unsure of the safety and efficacy of this helmet device in the bottom right for managing COVID-19. So from a monitoring perspective, both groups, the WHO and the Surviving Sepsis, strongly recommend close monitoring of these patients, and they kind of make weaker suggestions of trials of non-invasive if needed. The concerns that they cite: one is increased risk to healthcare professionals. They do consider this an aerosol generating procedure, and they cite some evidence of increased transmission with non-invasive ventilation versus high flow nasal cannula or conventional oxygenation. So in a time where we're very concerned about transmission of COVID to healthcare staff, something to think about. The next concern they bring up is a fairly high failure rate of non-invasive ventilation when it's used in non-cardiogenic etiologies of acute respiratory failure. They cite upwards of 50% failure rates. They cite a couple of randomized control trials, one that showed when acute hypoxic patients were randomized to non-invasive ventilation or high flow nasal cannula or conventional oxygenation, there was higher mortality in the non-invasive group. They cite some precedent data from the MERS outbreak, which suggest very, very high failure rates in non-invasive ventilation, over 90%, and that these patients had worse outcomes after intubation, like higher nitric oxide requirements and increased mortality. And finally, they have this concern of delaying intubation in patients like this, and that increasing the risk of these patients presenting for intubation when they're much more unstable, and that instability poses an increased risk to healthcare professionals if we're rushing through our intubation procedures. So the stance on non-invasive ventilation is a little more tentative. Suggested if high flow nasal cannula is not available, but consider these risks to healthcare professionals and the high failure rates. So now, to the meat of the talk is our mechanical ventilation strategies once the patients are intubated. So we'll start off with tidal volumes. And I guess we should just acknowledge at the beginning there's very, very little mechanical ventilation data for COVID-19. Obviously, this is a very dynamic, evolving thing. There are a few little trials coming out of the Chinese data to suggest certain things, but the majority of this evidence is based off ARDS evidence that already exists. They think it's reasonable to manage these patients in a similar way to respiratory failure and ARDS from other causes, non-COVID causes. So keys to that are low tidal volume ventilation. This has been consistently shown to improve mortality in ARDS. They recommend, both groups are in agreement with strong recommendations for low tidal volumes, 4 to 8 mils per kilogram of ideal body weight, not actual body weight. They suggest starting at 6 mils per kilogram. This reduces mortality. So this is a low-cost intervention that can reduce mortality. They cite multiple systematic reviews and meta-analyses and practice guidelines recommending low tidal volumes. So they suggest that starting at 6 mils per kilo, this is ideal body weight, which is based on the patient's height, as you all know. I would recommend, again, I didn't want to make too much opinion based on this. I would recommend having 4, 5, 6, 7, 8 mils per kilo of that patient's ideal body weight written somewhere at the bedside, like posted to the wall, because you're not going to be able to get your phone out and calculate it once you're in the room. It's a strategy that we know improves outcomes, so we should take it pretty seriously. The next thing they talk about is plateau pressures, and they recommend plateau pressures less than 30 centimeters of water. Again, this is part of that lung protective ventilation strategy to try and limit ventilator-induced lung injury. Plateau pressures have also been shown to reduce mortality and reduce lung injury. The combination of low tidal volume and low plateau pressures consistently in data has been shown to reduce mortality in ARDS patients. It's a low-cost intervention, and it's something we should be doing in every single patient. Practically speaking, you need some sort of inspiratory pause or no flow situation to measure a plateau pressure on a ventilator. If you're in a pure volume control mode of ventilation, you're going to have this escalating pressure time waveform like this, and so you'll need to add an inspiratory pause. And the reason we need an inspiratory pause is because if the gas is moving through the airways, then we're going to have some component of airway resistance that's being reflected in the pressure that we're measuring. So we need the gas to be still in order to measure a plateau pressure. If the gas is moving, then we don't know what component of airway resistance is influencing this pressure. If you're in a pressure control mode of ventilation, you get a square waveform of the pressure curve. So you're already kind of limiting the inspiratory pressure by definition. You can still add inspiratory pauses on most ventilators, and they'll give you a plateau pressure. So you're going to have to look at the vents that you have and figure out how you measure that. But it's important to measure it. The next thing we'll talk about is PEEP, high versus low PEEP. The evidence for PEEP is not as strong as the evidence is for plateau pressures and tidal volume. They suggest a high PEEP strategy over 10 centimeters of water and suggest monitoring carefully for barotrauma and also for limiting the driving pressure. We know from the 2015 trial in the New England Journal that all of these interventions of PEEP and tidal volume and plateau pressure, they only improve mortality if they resulted in a lower driving pressure, which would be your plateau pressure minus your PEEP. So make sure you're keeping an eye on your driving pressures. Obviously, there's no specific studies in PEEP for COVID-19 as it's so early. The idea is to promote lung protection and lung recruitment. The optimal level of PEEP in ARDS is unclear. It likely needs to be individualized to given patients. The systematic review evidence is not super clear in one direction. Some systematic reviews show that there's no overall mortality benefit with high PEEP, but there has been some mortality benefit shown in subgroups of patients who are PEEP responsive, which is kind of where that idea of individualizing this comes in. They make the suggestion for monitoring for barotrauma, and they also say consider using things like esophageal balloons or electrical impedance tomography to guide your PEEP optimization, although the efficacy of these are unclear at this point. Next up, we have fluid management. Again, no data on real data on fluid management for COVID-19. There was a small amount of data coming out of China for their results suggesting that cardiac failure, either alone or in combination with respiratory failure, was the cause of 40% of deaths, COVID-19 deaths in China. 44% of the patients had arrhythmias, and they sort of hypothesized that these patients have some degree of myocardial injury from this virus as well. And that's why they suggest a conservative fluid strategy. The WHO actually recommend this. They are a little bit stronger on their stance on this. We're considering that there may be an elderly cohort of patients who have COVID-19, and we've got to consider their ability to handle large fluid loads. Restrictive fluid strategies have been shown to reduce the duration of ventilation without having any difference in harms like renal failure and those types of things. Again, it's a low-cost, feasible solution, something we should consider. Prone positioning is the next thing they talk about. Their stance is that they suggest prone positioning for 12 to 16-hour sessions. The WHO actually are stronger on this. Again, they recommend prone positioning as it's been shown in various data to reduce mortality. There's recent data on prone positioning in COVID-19 out of China, suggesting 11 to 12% of the patients in their groups, ICU groups, were proned, but there's been no outcome data yet to see how those patients did. They referenced the Proceva trial, which showed that 16-hour sessions of prone positioning in ARDS improved mortality. They also cite some more recent systematic reviews showing mortality, reduced mortality in sessions longer than 12 hours. They do make a point to comment that proning sessions less than 12 hours have not been associated with improved mortality. So if you're going to prone patients, it needs to be for 12 to 16-hour sessions. They say to consider the risk of proning, of which there are going to be many logistically and otherwise. Pressure sores, line and tube obstructions, potential for brachial plexus and other peripheral nerve injuries. Contamination is going to be a big one for prone positioning. It's going to be very resource intensive having all of those people in the room to prone these patients. Are going to have lots of lines, tubes who are very sick, and considering PPE and contamination. So it's going to be a challenge to prone patients, but there does seem to be some benefit, and both guidelines suggest it. With respect to neuromuscular blockade, so there's the WHO suggests that you consider the use of neuromuscular blockers. The surviving sepsis guidelines suggest using PRN or like as needed boluses of neuromuscular blockers to facilitate protective ventilation. So if you're unable to get your plateau pressures below 30 and you've optimized your tidal volumes, you've optimized your PEEP, all those types of things, they suggest using PRN boluses of neuromuscular blockers to facilitate protective ventilation. They also suggest using continuous infusions of neuromuscular blockers up to 48 hours in the event of persistent dysynchrony with the ventilator, persistently high plateau pressures, or an ongoing need for deep sedation and proning. They cite a few trials for this. Obviously, the Perceiver trial, they cite a systematic review from 2013, which showed support for neuromuscular blockers and improving mortality. There was a 2010 study in the New England Journal which seemed to have positive impact on mortality, and then more recently the Rose trial that showed no outcome benefit. So there's this kind of inconsistent data there in terms of the benefit of neuromuscular blockers. So they suggest it be reserved for moderate to severe ARDS to facilitate lung protective ventilation when other strategies have failed. So more of a case-by-case basis for neuromuscular blockers. So those are the big ones, but there's some other things that they address in these guidelines. Next one is nitric oxide. So they recommend against the routine use of nitric oxide, and they justify that by citing the possibility of harms, including increased acute kidney injury and the absence of any mortality benefit in ARDS for nitric oxide. That being said, they do suggest a trial of inhaled nitric oxide as a rescue strategy in patients who have optimized ventilation, severe ARDS, and other strategies and adjuncts that we've already talked about have failed. They suggest it may be reasonable to attempt a trial of nitric oxide as a rescue strategy to improve oxygenation when everything else has failed. Having said that, they suggest monitoring for a response regularly and tapering off quickly if there's been no improvement. And they cite the risk of rebound pulmonary vasoconstriction if patients have abrupt stoppage of their nitric oxide. The next thing they talk about is recruitment maneuvers. So again, no specific COVID evidence for recruitment maneuvers, and the evidence for recruitment maneuvers in general is not that robust. I recently published a full video on recruitment maneuvers in ARDS, so I'll refer you to that. But essentially, their recommendations are, if patients are hypoxemic despite optimized vent settings, they suggest recruitment maneuvers versus no recruitment maneuvers. That's the surviving sepsis group. But they also suggest if you're going to use recruitment maneuvers that they recommend against the staircase recruitment maneuvers. And if you don't know what that is, go to that other video I published just to save time here. The WHO are not quite as strong on this. They just suggest considering the use of recruitment maneuvers, either staircase maneuvers or sustained inflation maneuvers, in patients who are still hypoxemic despite optimized vent settings. So there's fairly mixed evidence in terms of responders and non-responders to recruitment maneuvers, and that very often doesn't get included in these large trials, so it's difficult to figure out who's going to be responsive to these. So that's recruitment maneuvers. Those are the recommendations that they make. ECMO is the next one. They suggest ECMO for refractory hypoxemia despite optimized ventilation, proning, rescue therapies, and none of those have worked. They suggest using VV ECMO if you have it available in your center. Obviously, this is going to be an intense resource and infrastructure drain to have these patients on ECMO. Only very specialized centers are going to be able to do this. You're going to need to consider referral centers and where your patients will go. They do cite a 2019 RCT in the Lancet that found a decreased 60-day mortality with ECMO, but did have more bleeding. And the COVID-19 data, about 11.5% of the COVID-19 cases from China in this study that they cite received ECMO, but the outcome data for that hasn't been released yet. So again, case-by-case basis for ECMO. Other things that they mention which are worth talking about, one is avoiding ventilator disconnections. Obviously, firstly, for trying to avoid like nosocomial infection from hospital staff of COVID-19 by having ventilator disconnections. And secondly, for the patients themselves, like we don't want them to lose their lung recruitment and change their lung mechanics by having vent disconnections. So in order to facilitate that, they recommend inline suction catheters and clamping endotracheal tubes when you're disconnecting from the ventilator. So that's pretty much the summary of the guidelines. I wanted to keep this as brief as possible. This is a resource from the Society of Critical Care Medicine on their Surviving Sepsis webpage. I'll put all these links in the description below, and this essentially just summarizes those recommendations in mild and moderate to severe ARDS and the rescue and adjunctive treatments. So this is a good thing to kind of keep on your phone, saved in your favorites of your pictures or something, so you can refer back to it when you have to look after these patients. Hopefully this is helpful. Hopefully it saves you some time reviewing those big guidelines. Stay safe out there and best of luck.